Now, as you know, Ebstein's anomaly is a rare congenital malformation of the tricuspid valve, but not only of the tricuspid valve, because usually all the right cardiac cavities are involved. And as you see here, probably there is a lot of resorption between the tricuspid valve and this muscular trabeculization during the intrauterine life. Unfortunately, I'm not able to show the videos because the beamer is not compatible with my Mac. And as you see here, according to the displacement of the septal leaflet towards the apical portion of the right ventricle, there is, according to the Carpentier's classification, there is 4 types. Type A, here as you see is type B. There is a small displacement of the posterior septal leaflets. This one is a type B. As you see here, the septal leaflet and the posterior leaflet are here, very close to the apical cavity. The tricuspid, anterior leaflet of the tricuspid valve is completely immobile. And here you have a type C, as you see here again, a huge displacement towards the apical portion of the right ventricle with an anterior leaflet. Unfortunately, it's not moving, but there is a good mobility of the anterior leaflet. Now, regarding the targets of the surgical repair, first, the surgeon has the obligation to restore a normal volume of the right ventricular cavity, achieve a non-obstructive diastolic flow, and normal function of the tricuspid valve with limited or no regurgitation. And then, in the majority of cases, we know very well the pre-op right ventricular contractility is affected, and the surgeon has also to, during surgery, preserve this affected pre-op right ventricular contractility. And because this one, if it's not very well preserved, this one could be catastrophic after surgery, and for autism is one of the most important issues in the surgical treatment of the Ebstein's anomaly. Now, regarding the techniques we developed over the past, I would say, 30 years, the first one was the transverse plication of the atrial chamber. As you see here, the atrial chamber is here. The transverse plication, and Danielson, who was doing this transverse plication, who was first described by Lehigh and Hardy in '62. And he published his results in the Journal of Thoracic and Cardiovascular Surgery in 1992. The operative mortality in his series was 7.3 with a late mortality of 11%. And then Carpentier changed a little bit the plication technique. He started doing the longitudinal plication, the clockwise repositioning of the tricuspid valve, and systematically arencanuloplasty. And he published his results in 1988. And as you see here, the majority of his cases were type C, D. The operative mortality was 10%. 9% of his cases needed redo surgery. The actuarial survival at 10 years was 75%, and 22% of his cases needed Glenn anastomosis. And then Kohn da Silva developed the Kohn technique. It's a modified Carpentier technique with, in some of the cases, with a partial plication of the atrial chamber, and he also published his results in the Journal of Thoracic and Cardiovascular Surgery in 2007. As you see here, the mortality in his series is low, 2.5%, and only 5% of his cases needed at 4 years redo surgery. Regarding the Glenn anastomosis, Chauveau, who was one of the consultant surgeons in Carpentier's team, published in European Journal of Cardiothoracic Surgery in '98 the use, the association of the Glenn anastomosis with the surgical treatment of the Ebstein's anomaly. As you see here, the operative mortality thanks to the gland anastomosis decreased from 24 to 0%. The reoperate decreased from 11 to 0. And there is an increase of survival at 5 years from 66 to 80%, but unfortunately the rate of residual tricuspid insufficiency did not change, and in 26% of cases there was, at least I will say, moderate degree of tricuspid regurgitation after surgery. Now, regarding the indication, Chaudot proposed that in all cases of massive or long-standing tricuspid insufficiency, in all cases of type C and type B Ebstein's anomaly, in all cases of New York Heart Association class 4, and in all cases of permanent atrial fibrillation, the surgeon has to associate the surgical treatment of Ebstein's, the tricuspid valve repair, with a gland anastomosis. Now, just after my training with Carpentier, I started also having a big interest in the surgical treatment of Ebstein's anomaly. And over the past 21 years, I operated 124 cases. And as you see, I had 100 cases now. I didn't put the last cases I operated in Mitera Hospital, type C and type B, as you see here. The mean age was 16 years. Now, what we started doing, especially systematically, I'm asking MRI for all cases, because I believe it's an ideal diagnostic tool. You have all the anatomic details, the end diastolic volumes, you have a very clear idea on right ventricular function. And then I started also following up my cases with MRI to check a little bit what it happens for the post-op right ventricular remodeling. As you see here, you can see clearly the tricuspid valve. Unfortunately, I lost some always the contractility of the right ventricle, the mobility of the leaflets, and you can also measure what we started doing, because as you know, there is sometimes, especially in type C and D, the septal leaflet is very close to the apical portion, and the anterior leaflet is sometimes completely immobile. I believe you cannot correctly measure the whole right ventricular cavity, and we started measuring the infundibular portion of the right ventricle. Because I believe it's the most accurate part in terms of measurement. And for a reason, I wanted to know exactly what is the evolution in terms of this anti-diastolic right ventricular volumes, and I will show you what we have. Now, I modified a little bit the surgical technique described by Carpentier. It's a modification of Carpentier. First, if there is dyskinesia, I check the pre-op echocardiography. If there is dyskinesia, I do a central partial plication of the dyskinetic segment in order to convert the dyskinetic segment into an akinetic one. Because we know very well the hemodynamic consequences of dyskinesia are worse than those of akinesia. If there is no dyskinesia of the atrial chamber, I stop doing plication. And then I do the clockwise rotation of the anterior and posterior leaflet. I will show you the technique, the plication of the tricuspid orifice. I started putting rings because I believe it stabilizes the native ring, and it prevents also the recurrent risk of tricuspid insufficiency. And I do systematically, I reduce the dilated right atrium. As you see here, finally, here the true right ventricle is here preoperatively, and by this technique with no plication or a central partial plication, finally, yes, finally you have a very good right ventricular new cavity. Oh yeah, this one is the technical slide. As you see here, the septal leaflet. We completely detach 2/3 of the anterior leaflet, posterior leaflet, and sometimes if there is some remnants of the septal leaflet, completely the septal leaflet. We plicate, according to the surface of the anterior leaflet, we plicate the tricuspid, the dilated tricuspid orifice, not at the level of the insertion of the septal and posterior leaflet, but at the level of the physiological tricuspid annulus, not at the level of the anatomy. And then you reattach the detached leaflets anterior by doing a clockwise rotation. And we also mobilize the anterior papillary muscle because sometimes it's completely immobile. There is a lot of trabeculations. And sometimes I also create, by detaching some part of the right ventricular trabeculation, I try to create a septal or septoposterior papillary muscle. Now, regarding the postoperative evolution, as you see here, I had one case which needed a right ventricular assist device with early heart, and then we successfully went from the ventricular assist device on 9th postoperative day. And the majority of the patient was in sinus rhythm. You have to be very careful when you reattach the leaflets, the detached leaflets to the native annulus, especially at the level of the interventricular septum. And then regarding the last echocardiographic controls, as you see here, it's true that in 50% of cases, I had residual tricuspid insufficiency grade 1 and 2. Only in 2 cases, I had more than moderate degree tricuspid insufficiency, as you see here. And especially in type D also, there is the percentage of residual tricuspid insufficiency is higher than the remaining types. Regarding the tricuspid gradient, as you see here in type C, the mean gradient was 3 millimeters of mercury. In type D, around 5, which is mild to moderate tricuspid valve stenosis. And this one, unfortunately, is the surface of the anterior leaflet, which will determine the surface of the tricuspid orifice. There is nothing to do. There is now some surgeons doing pericardial patch enlargement of the anterior leaflet, but as you know, the fate of this pericardial substitutes is not very clear. They calcify, and I believe it's better to preserve the native tissue, valvular tissue, than to add something new, which can compromise the long-term outcome of these cases. Regarding my experience regarding the MRI, as you see here, in no plication, because if there was no dyschezia, I stopped plicating the atrial chamber. 27 patients had no plication, and as you see here, the anti-diastolic volume index at 6 years is quite good. In a partial plication with dyskinesia, I do a central partial plication, as I mentioned, to convert the dyskinesia into akinesia. 40 patients compared to the no plication group, the anti-diastolic volume index is a little bit smaller, and 8 out of 74 patients underwent associated gland anastomosis. At the beginning of my experience, I was trained by Carpentier, and I started, plicating all the atrial chamber, no dyskinesia, akinesia, and here, when I took again this patient back to control, and then as you see here, compared to the no plication or central partial plication group, the anti-diastolic volume index, they are very small. And all these patients had undergone gland anastomosis. The pre-op anti-diastolic volume we measure at the infundibular portion for type C and D is usually 25 millimeters. And finally, I have a cutoff value now. In cases in which the pre-op anti-diastolic volume index is less than 17, I know that I will be obliged to do an associated anastomosis. And for this, you know, again, is the role, the important role which plays the MRI in the decision-making process of these cases. Now, I don't want to prolong because I don't have time. What we have learned, I have learned based on this personal experience. First, as I have already mentioned, the amount of functional tricuspid tissue will determine the surface of the new tricuspid orifice. There is nothing to do, and I don't prefer to add new material, pericardial material, and compromise the long-term outcome. The ring annuloplasty, because in some of my cases I didn't put in ring, and then I noticed that the ring annuloplasty decreases the rate of recurrent tricuspid insufficiency and that of paravalvular leaks over the follow-up period, probably by decreasing the tensile stretch which will be applied on the native tricuspid annulus in terms of tricuspid orifice. And then no plication or partial plication technique of the atrial large chamber will increase the volume of the new right ventricular cavity, resulting in less need for Glenn anastomosis. Again, the total plication of the atrial large chamber or pre-op and diastolic volume index below 17 is a predictive risk factor for Glenn anastomosis. Again, I repeat, MRI gives more reliable information regarding the right ventricular and diastolic volumes. And now, the magnetic resonance imaging should be a must in pediatric cardiology and in pediatric heart surgery. In patients operated before the age of 10 years, no plication or partial plication induces right ventricular remodeling, because what I noticed, the thickness of the atrial large chamber, which is not plicated, progressively increases. But I need, you know, some more data because I don't want to publish something bullshit. And for this reason, I'm measuring now the thickness, the evolution in terms of thickness of the atrial large chamber. And for this reason, again, probably we have to operate during the early stage of these cases in order to induce, to promote this remodeling process of the right ventricular, of the atrial large chamber. Again, less rhythm and conduction disturbances in no plication group compared to total plication, which is very evident for me. And there is no potential risk of right coronary injury with no plication because, as you know, there is the posterior descending branch of the right coronary artery, and sometimes, unfortunately, when I was with Professor Carpentier, I have the memory of 2 or 3 cases in which we had post-op myocardial infarction, and unfortunately one of them died. For the reason, you know, if you can avoid the plication, avoid it. And now, you know, the big question at this stage is, should Ebstein cases be operated on a asymptomatic or mildly symptomatic stage in order to preserve a better right ventricular function? But it's true, like in the surgical repair of mitral valve disorders, this approach will need also surgical expertise. Regarding the congenital mitral valve repair, again, you know, it's clear there is 2 surgical management options, replacement, and usually we prefer the mechanical prosthesis at the age over the bioprosthesis, and the other one is repair. Now, regarding the anatomy, for me there is 3 groups of congenital mitral valves. The first one is the dysplastic reflex, and usually here there is the papillary muscle to commissure fusion. I will show some slides. The parachute mitral valve, the Hammock or arcade valve, and sometimes this dysplastic mitral valve could be also part of Schwann complex or hypoplastic left heart syndrome. And then you have the second category of patients with normal leaflet anatomy, and here we have the prolapse of the anterior leaflet and or posterior leaflet, and the mitral insufficiency due to primary annular dilatation. And then the Third group is the mitral malformation associated with connective tissue disorders like Marfan and Lardon-Loss, Williams, and so on. The isolated anterior leaflet cleft, which is the most frequent congenital mitral valve anomaly, I believe I cannot put into any of these groups because the leaflet anatomy is not normal. The leaflet, the tissue quality, I cannot say that it's dysplastic, and there is no connective tissue disorders in this pathology. And for reason, I put as apart and isolated, in an isolated category. Now, look here, the papillary muscle to commissure fusion or short chordal tendinea. This one is a short chordal syndrome. This one is the anterior leaflet of the mitral valve, the anterior and posterior papillary muscles with the short chordal tendinea, as you see here. It's a mixed, usually this one creates a mixed mitral dysfunction, insufficiency plus stenosis. This one is a papillary muscle to commissure fusion. As you see here, this one was the anterior leaflet completely here, very short chorda, but this part was completely attached to the ventricular surface of the commissure. Here is the parachute valve with a single papillary muscle, because sometimes you have also the second one is hypoplastic, but this one was a true parachute single papillary muscle, as you see here. All the chorda tendinea, primary or secondary, were arising from this single papillary muscle. The hammock or arcade valve, this one is a hammock valve. What is the difference? And this one is arcade. As you see here, it's an arcade. You have two papillary muscles, anterior, the posterior. Usually they are completely stuck into the left ventricular wall, and the free edge of the anterior leaflet and as well as of the posterior leaflet is like an arcade, and there is no paramedian chorda tendinea. There is a very strong fibrous reaction between these two papillary muscles. The hammock valve, as you see here, there is an anterior papillary muscle, which normal primary and secondary chorda tendinea, but look the posterior part of the mitral valve. There is no posterior papillary muscle. There is some kind of muscular trabeculation giving some kind of chordal attachments to the posterior leaflet, as you see here, multiple muscular trabeculations. This one is also a mixed mitral lesion. Now, regarding the anatomical background, the commissure to papillary muscle fusion, short chorda tendinea, parachute valve, hammock, fibrous arca, there is predominant, I would say, mitral stenosis, or they create a mixed dysfunction, mitral regurgitation plus mitral stenosis. And in this group, as I showed you some specimens, there is lack of valvular tissue. Now, regarding the congenital mitral regurgitation, which is according to the Carpentier's classification type 2, you have the elongated chorda tendinea syndrome, as you see here. It's a very beautiful specimen with an elongated head of the anterior papillary muscle, elongated primary chorda, creating a prolapse at the level of the corresponding part of the mitral valve. This one is a congenital Barlow. As you see here, there is an excess tissue at the level of anterior leaflet as well as of the posterior leaflet. And when you see the Barlow valve, there is also a lobular aspect, as you see here. This one is P3, P2, the lobular excess tissue, a lot of mitral tissue and lobular aspect. Now, regarding the surgical technique, okay, I know that many of us, we are afraid of touching the mitral valve, but I can tell you the valve tissue is not a no-touch zone. And especially, you have to touch, you have to detach the posterior and sometimes the anterior leaflet, what I am doing. Because, by detaching the posterior leaflet, you can enhance the vision on the subvalvular apparatus. You can mobilize better the papillary muscles, and you can work better on the papillary muscles. You can increase their mobility, and especially, which is very important in the surgical repair of Hammock valves. And then even, in some cases, you can do an effective commissurotomy by going and inspecting below the commissures. Now, regarding the techniques for the correction of type 1, and all of them, the majority of them are described by Carpentier, the wedge resection. If all the primary chordae tendinea are elongated, you can make a wedge resection on the papillary muscle according to the degree of prolapse. And then you close this resected part with separate stitches, and you correct, by this way you correct the prolapse. Or you can use an artificial cord, as you see, is what I do. I split, because especially in pediatric population, the most difficult part is to adjust the length of the artificial cord. And for this reason, usually I measure a normal primary chordal tendinea. I cut a small part of a tourniquet, and then I pass my artificial cord through this, and I split longitudinally in order to be able to remove it. And then I adjust by this way, and I have usually no problem. And when you tie on the papillary muscle, you can, thanks to the longitudinal split, you can easily remove the small part of tourniquet. Again, the chordal transfer, you have two sources. The secondary chorda tendinea, as you see here, there is an elongated primary chorda tendinea here. You detach the secondary one, and you reattach this one at the level of the elongated primary chorda tendinea. Or, the second source is the primary posterior chorda tendinea, which can go to the corresponding part of prolapsing anterior leaflet. Or, you can do this chordal shortening technique, again described by Carpentier. You create a flange, and you bury into this flange, according to the degree of prolapse, the excess length of the elongated primary chordae. Or, if the primary chordae is elongated and thick, you can do the sliding plasty. You detach the part of the posterior of the papillary muscle from which this elongated cord is arising, and then you go down according to the degree of prolapse. For example, if the prolapse is 3 millimeters, this distance should be, you have to respect this distance, it should be also 3 millimeters. Otherwise, you will create a restricted motion of the anterior leaflet, which is not good, because the regurgitation will persist. Regarding the dysplastic leaflets, again, for the correction of this dysplastic leaflet, there is no enough valvular tissue. Here, the enlargement techniques are very useful. In the majority of cases, we have to enlarge the anterior leaflet. As you see here, we detach from the insertion of the anterior leaflet to the native annulus, and we put a pericardial patch. Or, as in Hammock valve, we detach the posterior leaflet from its insertion to the native annulus, and we put a patch, and then, as I told you, in Hammock valve, there is a lot of muscular trabeculations, and you have also to detach this muscular trabeculations from the left ventricular wall in order to give more mobility, because in the Hammock valve, the stenotic component is more predominant. Again, as you see here, this one is also a dysplastic valve. Between the primary chorda tendinea, there is no a lot of space. You can make a resection in order to increase the mobility of the primary chordae tendinea. If there is a fusion of the commissures, you can do a commissurotomy, again, increase the space, the intercordal space, as you see here. In case of single papillary muscle, we have to split the single papillary muscle, the parachute papillary muscle, into two parts, and remove also and enlarge this intercordal space by resecting this accessory tissue. In case of valvular tap, as you see here, you have to remove and then split the papillary muscle in order to increase the mobility, as you see here. And this one is also a predominant mitral stenosis, the presence of valvular tap tissue. Now, regarding the annuloplasty, the rationale of the annuloplasty in children is that you have to maintain the relationship between valve tissue area and the surface of the mitral orifice in systole. But the big problem, as you know, children are supposed to grow up, and your ring is also supposed to allow for growth and to grow up according to the general growth of the child. For me, the annuloplasty is mandatory for all cases of mitral regurgitation, and in some cases of mitral stenosis in which I'm obliged to do commissurotomy. Because if you do commissurotomy, I will say, you know, usually what I notice is you have some residual leaks through the split commissures. And for that reason, you know, you have also to reestablish a good coaptation surface at the level of both commissures. Now, what are the annuloplasty techniques? Many surgeons proposed in pediatric population, as you see here, with a pericardial patch or band or a Gore-Tex band, you can do a posterior annuloplasty, and okay, you will condemn the growth of the posterior part and of both commissures, but you will leave free the anterior part of the native annulus, and this part will continue to grow up. Or, you know, sometimes the posterior annular dilatation is not symmetrical, and in these cases, okay, if you have the intention that this segment of the posterior annulus is more dilated than this segment, you know, what I do, in some cases, I do separated plication here, and more important plication at the more dilated part of the posterior native annulus. Or then this one is the K-Wheeler commissuroplasty, which was proposed many years ago. As you see, you plicate both commissures. Unfortunately, I don't like this technique. Because first, this part between the plicated commissures can redilate. And then here, you know, you create a huge fibrous reaction. And when you lose the mobility at the level of the commissures, sometimes you increase the gradient, the transmitral gradient. And sometimes it's an ongoing process over the coming 10 years, because sometimes, you know, I had this kind of cases, and I noticed that the gradient is becoming more and more important. And when I reoperated these children, unfortunately, it's impossible to do commissurotomy, to open this area, all the primary commissural chordae tendinea. I believe it's not a good technique. But on the other hand, this one, which was described by Panet and Gerbaudet with a pericardial strip application with a 5-0 polypropylene suture, and then the reinforcement with the pericardial strip. Okay, this one, I believe, is a good technique, because you can prevent the recurrent dilatation of the posterior native annulus, and the anterior part will continue to grow up. And then, as you know, we develop in Geneva, in our basic lab, the biodegradable ring. Short information about that. As you see, the ring is implanted into the native posterior annulus. As you see here, the left atrium is here, the left ventricle is here. This one is the insertion of the posterior leaflet of the native annulus. And as you see here, 1 month later, there is some fracture at the level, and some resorption at the level of the biodegradable ring, which is polydexanol with a specific molecular weight. and 6 months later it produces a strong fibrous reaction, and 12 months later, as you see here, 6 months after the complete degradation of the ring, there is still a persistent strong fibrous reaction. And this fibrous reaction, because we know very well that the fibroblasts in children can go up. Because when they are small, you know, you do a small incision, and according to the general growth of the child, the length of the incision is also growing. It's the same aspect. Here also, according to the general growth of the child, this induced fibrous tissue will continue also to grow up. Now, sometimes, you know, you have, unfortunately, residual mitral dysfunction. You do everything you can, despite your good experience. And if it's not good, it's not going to get better. This one, you know, you have to accept. But the cardiologist, I believe, gives a lot of information, especially with the three-dimensional echocardiography in these cases, because, you know, he can or she can estimate better the volume of the regurgitation. And sometimes the cardiologist can give a better information regarding the mechanism and location of the residual insufficiency. And then the big question is, can the surgeon do better? If you have the impression that the surgeon you cannot do better, don't touch. Because usually, you know, things go wrong. Now, in conclusion, I can say the repair can be palliative or semi-palliative operations during infancy and childhood with stenotic or mixed lesions. Here, your policy should be by time. You have to consider what you do in terms of repair is a bridge operation to a late replacement in order to be able to implant a bigger size mechanical or biological, if the case is FMA, biological prosthesis. You have to accept some residual stenosis or regurgitation. It's an important message to cardiologists who go down to the operating theater and tell, it's not perfect. It's not for you after that. And then this one is compromised. You have, you know, to establish the compromise. If you have good expertise and you have, you know, the impression that you did everything you can do, and then there is no more flexibility on the technical part, stop. And repair is durable in the majority of cases with pure congenital mitral insufficiency. Here, really, we have very good results. You have to avoid procedure preventing the growth of the annulus, you know, especially with this traditional rings, and for that reason there is no pediatric sizes. And then you have also to avoid additional procedures leading to technically complex operation to treat residual lesions with prohibitive high risk. Thank you very much.